started with basics of CT chest protocols. And we are all aware of the basic scans, the non-contrast CT scan that we usually perform for detecting infections, nodules, masses, pneumothoraces, effusion, trauma, and even calcification. Then one of the very highly ordered modalities is HRCT chest, which has thin sections ranging from zero point 0.5 to less than 1.5 mm. And it is again a gold standard for your interstitial lung disease patients, bronchiectasis, emphysema. Then low dose CT scan, which is done for nodule surveillance or for lung cancer screening. Contrast enhanced CT scan is what highlights your vascular and viable tissues. It also helps you to differentiate between necrotic from enhancing masses. Then when you come to the CT pulmonary angio, this is basically done to detect pulmonary embolism and systemic arterial phase, aortic as well as bronchial CT, and a delayed phase is also done to detect pulmonary embolism. Functional CT scans can be done to detect air trapping, and then there are dynamic CT and perfusion scans for specific conditions. Now, when we look at the CT, why the windowing is important and what is windowing? Windowing is basically, a CT can capture 4,000 grayscale shades, and human eye can only perceive about 120 to 180. So windowing basically optimizes your visualization by narrowing your displayed grayscale range. And why it is important is because we come across these windows in our CT scans that we frequently order for our patients, like the lung window, which helps you to visualize airways, lung parenchyma, ground glass opacities, nodules, mediastinal windows, which helps to visualize soft tissues, heart, great vessels, and lymph nodes, and the bone window, which helps you to visualize the bony structures. Now, once your scans are taken, there are advanced post-processing tools available, which help you to identify specific extents, specific vascular mappings, cysts, air trapping, and other diagnostic modalities. So these specific processing tools helps you in identifying the specific things that you're looking for from your scans. A systematic approach to a CT scan, to a CT reading is very important because it prevents missing subtle or incidental findings, and it ensures a structured review. You do not miss out on something even small on your CT scan. So when you look at the stepwise framework, you start with your airways, you look at lung parenchyma, then you look at the mediastinum, vasculature, pleura, diaphragm, and always the upper abdomen. Now, when we talk about the essentials of HRCT, which we very widely use, you need to know that if you're suspecting ILD, you need to prescribe and write the proper and essential parts that you need to see on your CT scan. For example, you need to mention complete that you require a supine, an inspiratory, and an expiratory scan, as well as a prone scan. So this is something which should be emphasized upon. You should know what you're ordering. You should know what you're looking for. Clinical acumen is always very important. Things should always be clinically correlated, and an appropriate and scan should be advised so as to not miss out on the subtle details as well. Now, when we talk about prone imaging, Dr. Dalil emphasized, why prone imaging is important, because it helps you to differentiate a true pathology from dependent changes. For example, look at this scan. As you can see in supine, there are certain ground glass opacities that you can see, shadows you can see at the basis. Now, when the prone scan was taken, they've completely disappeared. So less likely that these are pathological. Another scan wherein, at the basis you see some shadows, and then when you do a prone scan, they persist. So most likely this is a pathology. So there is an importance of prone scan. This is why you should prescribe and you should write the correct requirement from your scan. Now, expiratory imaging, which is used to detect air trapping, is useful in small airway diseases. And this I will be talking about a little more in detail as we go ahead. Now, coming on to the pulmonary interstitium, when you look at the secondary lobule, which is a very important structure, and you need to understand the very basics of a secondary lobule in order to be able to interpret your CT scans of the chest. Now, this is basically a smallest functional unit of the lung structure visible on imaging, typically on an HRCT chest. It measures about 1 to 2.5 centimeters in diameter. It is supplied by a lobular bronchiole in the center, which divides into terminal bronchioles, and then there are 20 to 30 acinus per lobule. In your periphery of your secondary lobule, run your pulmonary veins and your lymphatics. The artery is in the center of the lobule. Why it is important is, as we go ahead, you'll understand. Again, look at this figure. You can see that in the central core of this secondary, this hexagonal structure, which is called your secondary pulmonary lobule, is your bronchiole and the pulmonary artery. And in the periphery, you see the pulmonary veins and lymphatics. There also runs there is a two lymphatic system that runs along the secondary lobule, which is a central network and a peripheral network. Now, again, when you look at this figure, you can see that in the central part of the secondary lobule, the diseases that occur here are usually enter the lung through the airways, like your hypersensitivity pneumonitis patients, your centrilobular emphysema, and your respiratory bronchiolitis patients. Now, when we look at the perilymphatic areas, the site of the disease is again located in your lymphatics and also in the interlobular septa. So this, when you see the pathologies here, this is when it is your perilymphatic uh, area which is affected. As we discuss diseases, you'll understand why secondary lobule is important. Now, you must have a structured approach to your CT. A systematic approach is to identify one by one and then go on to a structured approach to identify the dominant pattern. What is the pattern that is dominant on your CTs? You might have more than one pattern, but what is the dominant pattern, which will help you to identify the underlying disease? So when you look at the dominant pattern can be reticular, nodular, high attenuation, low attenuation. Then where is it located? We just talked about the secondary lobule. Where is it located? In centrilobular distribution, perilymphatic, or random? Then whether it is in upper or lower zone predominance, central or a peripheral predominance. There can be various other additional findings like pleural effusion, lymphadenopathy, and traction bronchiectasis. So when we talk about the dominant reticular pattern, which means too many lines, fibrosis basically. So reticular pattern can have septal thickening, which is basically your thickened lung interstitium with fluid, fibrous tissue, or infiltration by cells, which results in reticular opacities due to thickening of the interlobular septa. Now your septal thickening can be smooth and can be nodular. When you look at this CT slice, you can see that there is a secondary lobule, right? Now, in this lobule, you can see that the thickening of your septa is smooth, right? If you can identify, this is relatively smoother. So this is an example of a smooth septal thickening. Now, when you look at this CT slice, you can see again that your interlobular septa are thickened, but this is more of nodular, nodular septal thickening. So this is an example of nodular septal thickening. For example, we just talked about lymphangitic carcinomatosis. Now, another reticular pattern that we see is honeycombing. Now, honeycombing is basically defined by small cystic spaces. As you can see here, there are small cystic spaces lined by bronchiolar epithelium with thickened walls composed of dense fibrous tissue. Now you can see that there are multiple small cystic spaces. These days they say that a single line is enough to identify honeycombing. In this, you can see that there are multiple layers of these small cystic spaces. And this is something that we typically see as a feature of your UIP, IPF pattern. Then when we come on to the next pattern, we see the nodular pattern, that is too many dots, small nodules. Now we'll talk about nodular pattern. So your nodular pattern can be perilymphatic in distribution. It can be along the pleural surface. It can be in your interlobular septa. It can be along your fissures. Your nodules can be present in the perilymphatic distribution. Then there can be a centrilobular, like we just talked about the secondary lobule. And in the very center of the secondary lobule, there can be nodules present. And then there is a random pattern of distribution of your nodules, which can be present across your lung, across your secondary lobule. It can be any distribution, which is why it is called random. Now look at this CT cut. You can see that there are nodules which are present along the fissures, they're present along the pleural surfaces, and this is a pattern which is the perilymphatic distribution and is commonly seen in your patients with sarcoidosis. Now look at this CT cut. As you can see, within the center of your secondary lobule, you see ground glassing, and there are centrilobular distribution of nodules. So this is something which you often see in your patients with hypersensitivity pneumonitis, respiratory bronchiolitis, in patients who are in people who have been smokers. Then tree in bud. Now, tree in bud is basically an extension of your centrilobular nodules. And what is tree in bud is basically it represents your dilated and impacted, whether it is mucus or it is pus-filled centrilobular bronchioles. Where is it? Where do you commonly see this? This is commonly seen in patients with active tuberculosis. If you can see the CT slice, we can appreciate there's a tree in bud appearance here. Very commonly seen in patients with TB, but can also be seen in other infections, in airway diseases like cystic fibrosis, bronchiectasis, ABPA, and even in cases of aspiration sometimes. Now look at this CT slice. You can see random distribution of nodules across your lung fields. Now this is a result of hematogenous spread of infection, and it is commonly, these small nodules are seen in hematogenous metastasis, miliary tuberculosis, fungal infections. Now, coming back to summarizing your nodules, you have multiple nodules. You look at the distribution. Do you see pleural nodules? Yes, or do you not see pleural nodules? If you do see multiple nodules and there is presence of pleural nodules, then you look at whether there is a subpleural septal or peribronchovascular presence of nodules. Now, this sort of a presentation, pleural nodules, and this distribution is your perilymphatic distribution and is seen in sarcoidosis, silicosis, and lymphangitic carcinomatosis patients. Now, pleural nodules can have diffuse or no predominance as well. And this can be a random distribution, like just a CT slice we discussed, and can be seen in patients with metastasis, tuberculosis, fungal infections. Now, if you do not have pleural nodules, then it's a centrilobular distribution of nodules and seen in hypersensitivity pneumonitis, respiratory bronchiolitis, and bronchoalveolar carcinoma patients. Now, coming on to the third dominant pattern, which is the high attenuation pattern. Now, in high attenuation pattern, when we talk, first we talk about ground glassing and consolidation. Now, basically in high attenuation pattern, everything appears white. If your vessels are not obscured, then it is your ground glass along the haziness. If your vessels are completely obscured, then it is a consolidated lung, as you can see in this figure. High attenuation ground glass opacity is seen in acute conditions like pulmonary edema, pulmonary hemorrhage, PCP infections, chronic conditions like hypersensitivity pneumonitis, organizing pneumonia, NSIP pattern of fibrosis. Now look at these CT cuts. Now you can see that there is extensive ground glassing in both of them. However, in this, if you look, there is no fibrosis essentially, which goes to show that this is probably an acute condition, treatable condition. And again, when you look at this cut, you see there is ground glassing along with fibrosis. Probably goes to show that it is a chronic lung disease and probably not treatable. So then the other pattern of high attenuation is your mosaic attenuation. Basically, these are patchy areas of black and white lung. And this is basically used to describe the density differences between the affected and non-affected areas. Now look at this CT slide cuts. As you can see in this was taken during inspiration. And when you look at this dark area, can you see this black area? When you look at these areas, you see that there is thinning of the vessels also. Now, once this scan is taken in expiration, you see that these get enhanced, right? And there is thinning of vessels also seen through this. So I will just explain, and we did discuss about this. So this is in mosaic attenuation, a typical air trapping pattern, which is seen in small airway diseases. Another high attenuation pattern that we see is crazy paving. Not very commonly, but yes, it is seen. And it is basically what is the combination of ground glassing along with superimposed septal thickening. If you can appreciate on this scan, both the sides. condition that we generally talk about and we think of crazy paving as a spotter, you would always think, say, pulmonary alveolar proteinosis, but it can also be seen in various other diseases. Then we talk about high attenuation consolidation, which is another pattern of high attenuation, can be seen in infections, edema, fibrosis, tumors, as well as sarcoid or alveolar proteinosis. Now look at this high attenuation CT cuts. Can you see the distribution, this such high dense consolidation in the periphery? Now they're also patchy, right? So this is the differentials of this would be organizing pneumonia, chronic eosinophilic pneumonia. And then again, depending upon your patient's history, is when you basically identify the cause of this consolidation. Similarly, when you look at this, now this patient also had, you know, dense consolidation, high attenuation consolidation, but had a history of fever, had marked eosinophilia in the peripheral blood. So you would think of chronic eosinophilic pneumonia in this patient as the diagnosis. Now, coming on to the dominant pattern, I'm sorry, I meant pattern. This is the low attenuation, wherein you see the cysts. And when you talk about low attenuation pattern, it's basically filled lesions, more blackish lesions, right? High attenuation was more white lesions. This is more black. So you talk about the common low attenuation patterns are your honeycombing, traction bronchiectasis, lung cysts, signet ring, as well as centrilobular emphysema. Now look at these CT cuts. As you can see, one of the low attenuation patterns is seen in emphysema. And when we talk about emphysema, there is centrilobular emphysema. If you can see, along the lobule, there is distribution of emphysema, which is seen. This is one of the most commonly seen emphysemas and is strongly associated with smoking. Then the other pattern is the paraseptal, which is present along the pleural spaces, along your periphery, right? This is your paraseptal. And then it involves the complete secondary, the whole of the secondary lobule is involved. This is your panlobular emphysema. Then another low attenuation pattern that we see is your cysts, right? Look at these cysts in both these CT cuts. You can see that there are multiple round, bizarre shaped cysts. Now, this is the differentiating factor from bronchiectasis also. Can you see how bizarre these look? How they are multiple, they're round, but they're very bizarre. Look at their walls, right? So this is a case of Langerhans cell histiocytosis. Now, this was a 40-year female non-smoker, and she had multiple cysts. There's multiple cysts across her lung fields, and there's, if you can see, there's a large pneumothorax also. This was the case of lymphangioliomyomatosis. So you need to clinically correlate, you need to look at the presentation. You need to understand that there's always a combination of both. Never just blindly rely on your scan. Always keep in mind the clinical approach. Always have a multidisciplinary approach to your patient's diagnosis. So the key takeaways that were discussed by Dr. Talil and Dr. Irodi were basically that CT protocols must match your clinical question. An HRCT chest for your ILDs, emphysema bronchiectasis patients, CTPA in cases of suspected pulmonary embolism, low dose CT for screening and follow up, contrast CT for masses, infections, and vascular lesions. Windowing and post processing are crucial. Prone and expiratory imaging matter. It helps you to differentiate between real disease from dependent changes, and it also detects air trapping and small airway disease. Use the secondary pulmonary lobule anatomy. Remember, understand it very well to be able to interpret your CTs easily. There can be a centrilobular distribution in airway diseases like hypersensitivity pneumonitis, respiratory bronchiolitis, perilymphatic, like in cases of sarcoid, lymphangitic spread, random in cases of miliary TB, metastasis. Then pattern-based approach, reticular in cases of fibrosis with septal thickening, nodular in sarcoids, infection, malignancy, ground glass for your inflammatory conditions, edema and fibrosis, low attenuation. We've talked about emphysema and cysts, and then crazy paving and mosaic attenuation are key signs in specific contexts. Always follow a fixed approach, have a systematic approach so that you avoid missing subtle signs and avoid missing the findings. Thank you.